Okay, just two more discussions here today on equipment oriented now toward the end of the day. What a ventilator is right for you, and then my colleague Carol will be discussing interfaces. Just for my disclosures, I do, obviously I work for ResMed, as you know, and I also work part-time as a respiratory therapist. I take care of home ventilator patients. So I think everybody's pretty up on the terms, and it's funny, each year we're kind of preparing for the next year, and last year we did have a couple of trach patients that visited us for the symposium, but I don't think we have any here today. But just wanted to make sure that we're all clear on the terms. Non-invasive, obviously, is not inside the body versus invasive ventilation. So here you can see we have a endotracheal tube, this is in the person's mouth, or a tracheostomy tube. Generally, the endotracheal tube is done on an emergency basis or for surgery or whatnot, but you wouldn't want to have that long term, that would be uncomfortable. So if it looks like the person's going to be on the vent for a while, then we switch to the tracheostomy. So just so you can see, I do distinctly remember last year one of the questions after the session was, can you eat if you have a tracheostomy? And so I just wanted you to see this is the path for the airway and this is the path for the food. So they are separate pathways. So some of my trach patients can eat normally without a problem, but other patients, if they were trached because they have difficulty managing their secretions, if they have that muscle weakness that Dr. Bendit talked about with the muscles of swallowing, then of course they're not going to be able to eat because they would choke. So each patient is different on whether or not they can eat with a tracheostomy. Kind of goes back to why they had that trach. I just added this slide quickly because somebody was asking for the signs and symptoms of hypoventilation. Now remember, hyper means too much, so hypo means not enough. So I real quick found this slide from another lecture. This is some information from Dr. Bach, I think, just going through a lot of the signs and symptoms of not enough ventilation. So frequent hospitalizations for SOB, I guess I better explain what that means. I just saw that. That means for shortness of breath. So I don't think they hospitalized you just for that other reason. So atelectasis is when parts of the lungs collapse. Of course, you know pneumonia, oxygen therapy. Of course, I think we've talked about this in the past at our symposium, that sometimes we put patients on oxygen when the real problem is that they're not moving enough air, right? So we know generally oxygen is not the treatment for hypoventilation. Morning headaches, I think this lady over here talked to us about that a little earlier today. Fatigue. Daytime hypersomnolence, that just means being sleepy during the daytime. Frequent awakening with tachycardia, that's that fast heart rate. Frequency enuresis, having to get up to go to the bathroom a lot. Nightmares. Now this one's interesting that I'm told, I don't suffer from this myself, but I'm told that a lot of the nightmares will be respiratory related. Feeling like I'm drowning or someone's choking me or there's a weight on my chest or something to do with not being able to breathe works its way into the subconsciousness. Loss of concentration, memory problems, personality changes, weight changes, etc. History of CHF, congestive heart failure, like we just heard about, hypertension, nausea from the high CO2, low saturation or elevated CO2. So you can see that there is just a hodgepodge of these signs and symptoms that might be indicative for you of hypoventilation. So when you're deciding what type of ventilator would be best for you, there are a lot of considerations, a lot of things to think about. And I'm a respiratory therapist for over 25 years, so this is my chance to plug the respiratory profession. But there are so many different ventilators out there now, and they have some wonderful features. It would really behoove you to have a one-on-one conversation with a respiratory therapist to go through what your needs are, what your goals are, and your treatment plan so that the very best machine can be picked for you. We have to think about, are you going to get a tracheostomy at some point in the future? Is that something that you would do if you deteriorated to a certain level? Do you want a valve ventilator or a leak ventilator? We'll talk about that. Are you going to be ventilated with pressure or volume? What about leak compensation? Is that very important for you? How about portability, batteries? Are you going to be going on some trips? Do you want humidity? Any special features? And is it important for you to have data that you can download and share with, or your physician can download and share with you information about how you're doing during sleep? So what's the difference between a valve ventilator and a leak ventilator? Well, a valve ventilator somewhere in that circuit, somewhere in that breathing tube, has a valve that allows the exhaled air to escape out of that valve. Now, the advantage for that is that you can have zero PEEP, no PEEP or no EPAP with a valve ventilator. With a leak ventilator, one of the advantages, it's a much easier circuit. It's generally an easier machine to use, but you do have a minimum PEEP that's required to flush out that mask. So that would be an important distinction. Now, if you notice here on the valve ventilator, there are no holes in the mask. And you'll notice those masks are generally colored by the manufacturer. They usually make them blue. As a heads up, this mask does not have any holes in it for exhaled air. On the other hand, if you're using what we call a leak ventilator, there will be ports in the mask, so the exhaled air can escape out of those ports. But that's why we need that minimum PEEP or EPAP of at least 3 centimeters to flush that exhaled air out of those ports. We also call leak devices RADs, if we're using the terminology that Medicare uses, a respiratory assist device, or a RAD. That's another name for a leak ventilator. Now, because I also added in this slide, because there was some confusion earlier today, a couple questions on all these terms, it's like alphabet soup. We've got BiPAP, VPAP, NPPV, NIV, all these different terms. And what we all have in common is it's non-invasive, positive pressure ventilation. Non-invasive, positive pressure ventilation. So there's no tube inside of you. You're using some kind of mask or mouthpiece. And generally we're using 2 levels of pressure. We're using a higher pressure, an inspiratory pressure called the IPAP, inspiratory positive airway pressure, and then we're using a lower pressure, EPAP, expiratory positive airway pressure. The difference between those two is very important for patients like you folks with neuromuscular compromise or post-polio, because that difference between the IPAP and the EPAP is what moves the air into the lungs. We have to support your breathing with that difference. Now, some people call that difference pressure support, and other people call that difference the span or the delta. But in general, we're talking about if we take the IPAP minus the EPAP, we want a pretty good number there. I can't say in all cases you want at least 8 to 10, but certainly that would be something to discuss with your physician, that we want a big difference there, a delta or a span. So what are some of the advantages of a leak circuit? Well, it's pretty plain to see. This is a leak circuit, and this is a valve circuit. So you can see if you're using a valve ventilator, you see we have the blue mask because there's no holes in this mask. All the exhaled air is escaping through this valve. Well, you can say that that's probably not quite as comfortable because you've got additional weight and bulk up around your face. So most people think that a leak ventilator is more comfortable from that viewpoint. Also, there are far more masks made for leak ventilators than there are masks made for valve ventilators. So the chances that you could find an interface that would be comfortable for you is much greater if you're using a bi-level type device or a leak ventilator. Now, another very important consideration is to determine whether or not you're going to use the device, the ventilator, to the tracheostomy. We call it patient acuity here, or how sick the patient is. So a patient that's dependent, they absolutely must have that ventilator all the time in order to breathe. That's a dependent patient, and they need to be on a life support type ventilator. Most patients, though, certainly most patients here with us today, our neuromuscular patients, are what we call non-dependent. So they need the support, but they're okay for periods of time without the ventilator. So that's also something to keep in mind. If the ventilator is going to be used to the tracheostomy, then we're probably going to go more on the dependent type of ventilator. Another very important consideration is what type of breaths has your doctor recommended for you. You can have volume breaths or pressure breaths. So if we're looking at that Coke bottle, that's a big one. Anybody know how big a large Coke bottle is? 2 liters. Or how many milliliters would that be? 2,000 milliliters. So there's a certain volume. That holds a certain volume of air. So if we have a patient who weighs 200 pounds, and we divide that by 2.2 to give us the rough number of kilograms, that tells us that patient weighs about 90 kilograms. So a rule of thumb is we want to use about 10 milliliters per kilogram. So that patient has a pretty big tidal volume of about 900 milliliters, or almost half of that big Coke bottle there. So a certain type of ventilator can deliver a volume. Generally, valve ventilators will deliver a specific volume of air. On the other hand, leak ventilators all deliver to a certain pressure. It's kind of like filling up your tire on your car. You put that little gauge on there and you keep adding air until what? Till you reach a certain pressure. Well, we do the exact same things with your lungs. We keep sending air, that leak ventilator just keeps sending air until it knows that a certain pressure, the prescribed IPAP, has been achieved. So what about the modes of ventilation? We talked about that a little earlier today. We talked about how CPAP was probably not the best mode for most of us here today. So what modes are available? Well, we know that the valve ventilators offer a lot more modes than the leak ventilators, but in general, the leak ventilators are more comfortable. So the modes that we use on the leak ventilators, we can supply CPAP with a leak ventilator, but that's probably not the mode for you. We can also do a mode called spontaneous or spontaneous timed or timed. And I'll show you some more pictures of those here shortly. Now remember, spontaneous, spontaneous timed, or timed, these are all bi-level modes. So what you can call VPAP or BiPAP, a more generic term again is bi-level ventilation. So let's take a look at what those modes look like. Well, the first one here on the slide is the S mode, where we have an IPAP and an EPAP. Does anybody know what this little bump right there means? Any of my therapists know? Excellent. The patient made an effort right there, and the machine responded. But what if the patient doesn't make an effort? What's going to happen? Exactly right. In the S mode, nothing is going to happen, and that's not what we want for you folks, right? So as we talked earlier today, as Dr. Bendit mentioned to us, it's important for this group of folks to have what we call a backup rate or a breath rate. So we get that in the ST mode. Now you can see this breath was triggered by the patient, right? So we came from our EPAP up to our IPAP. But this breath over here was triggered by the machine because it waited a certain amount of time and there was no effort by the patient. So the machine stepped in and gave that breath for the patient. So you've got that safety and security. If you would quit breathing during sleep, the machine is going to ventilate you without you having to worry about it. Now the last bi-level mode that's available on the most leak devices is called the timed mode, but that what we call locks the patient out. No matter how hard the patient tries, he doesn't get a breath except when the machine gives him a breath. Obviously, that's not comfortable for you folks, so that's not what we want. So it's kind of a long explanation to say to you that probably everyone in this room wants the ST mode for them. Okay, now here's a picture. What's this a picture of, this mode? CPAP mode. Excellent. One of my therapists got that, and this is what we don't want. And can you see why? There's not a difference between the IPAP and the EPAP in this CPAP mode. So this is appropriate for people with obstructive sleep apnea. But it's not going to help you folks who have trouble with hypoventilation. So no CPAP for you. Okay, what about leak compensation? How many of you are currently using some form of nocturnal ventilation? Can I see some hands? Okay, so everybody here is using some kind of mask or interface, right? And of you that are using nocturnal ventilation, how many of you have ever had a leak with your device? Oh my goodness, I think every single hand went up. So we know that leaks are inevitable, aren't they? Sooner or later, you're going to move in such a way that you're going to move that mask a little bit and you're going to get a leak. Now, what happens when you get a leak? That can be a problem. Depending on the ventilator that you're on, a leak can be more or less of a problem. If you're on a good ventilator that has adequate leak compensation, that ventilator sees that there's a leak and it compensates for that lost flow to make sure that you're properly ventilated and the ventilator stays in sync with you. Now, when I say in sync with you, I mean when you ask for a breath, you get one, and when you want to exhale, you can. So if this technology works, I wanted to demonstrate this for you. So my good friend Sam's going to come up here and we'll see if this will work. Now start with no leak. And can you undo the ports so that when... Okay, so what we're going to do is we're going to start my friend Sam. I mean, is he a good volunteer or what? To come up in front of everyone on this CPAP for us. Now right away I could see he's got his glasses on, but he's got a good Resmed mask that's allowing him to wear his glasses. So what we're going to do, I've asked him just to hold the mask to his face, and he's got the 2 leak ports on the mask. They're extra ports that you can attach oxygen or pressure measurement. So I have him holding those shut. And you can see him breathing here. Now I'm going to ask him just to ride the ventilator if he can. And by that I mean I don't want him to take any breaths on his own. I just want the machine to give him the breaths. Okay. And I have him on an IPAP of 15 and an EPAP of 3. And if he's able to, just ride this machine. Let me get the pointer out so I can show you. Oops. No, I'll just use this one. Okay. These little triangles, let's see what we're looking at here first. It's kind of fun. These little triangles indicate a machine breath. Okay, so Sam, are you just relaxing the best you can? And he's what I call riding the vent. He's letting it do the work. So maybe this is you late at night when you're really sleeping deeply and relaxed. We can see his IPAP and his EPAP. This is showing his inspiratory flow, expiratory, inspiratory, expiratory. So we can see. Now we're going to have him make a big leak by removing his fingers from that mask. And we're going to see what happens there. Did you see? The minute he released the fingers, he had kind of a bigger breath there. Did you see? Right here. He released the fingers, had a big breath. Now it took only 1-2 breaths for the machine to get back in sync. Do you see how now the machine is back in sync with him? Okay, so he had one extra big breath, and then a little bit longer breath, and then back in normal, and then now he's back riding the machine. So what that means is the device watched he made that big leak, and it immediately gave him a breath when the leak was created. Did you notice that? Because it thought he was asking for a breath because he made that big leak. It thought he was asking for a breath, and within only 2 breaths, the machine was back in sync with his breathing. Okay, so that's what's crucial about your device. Now you can test this at home on yourself. Simply make a little leak and see how many breaths it takes for your device to get back in synchrony with you. Okay, now we'll see if we can close out of here and go back to a few more slides. And Sam has graciously agreed to stay up here with me. Oh, shoot. Oh, sorry. Because I do have another thing I wanted to show you. Oops, there we go. Okay, so let's take a look at that. That leak compensation, the device is watching that baseline flow. And as soon as we change the baseline flow, because we created that big leak we opened both ports on his mask, it took it just 2 breaths for it to recalibrate and adjust that baseline flow. So his next breath was back in synchrony. Now this shows you our wonderful S9 VPAP series is in the blue. And some competitive products are in the green and the red. And you might think, what the heck am I looking at here? Well, here we can see the flow rate along the bottom. And along the side here is the mask pressure. So here we have a pressure of 20. Here we have a pressure of 25. So that's a really high pressure. So let's take a look at that. In this particular example, the S9, the ResMed product, was able to come to a flow of, I don't know, what is that, about 180 liters a minute before the pressure dropped off. The competitive product, right here at a flow of about 120, then that pressure dropped off. So what does that mean for you? That means when you have a little leak, your mask becomes loose a little bit, and you have a leak, and flow is going out that leak. It means there's extra flow still available to maintain that set pressure for you. That's what's so important. We need a lot of extra flow in case you have a leak so we can maintain your prescribed pressure. So another thing I wanted to show you, especially important feature on the ResMed products, is called TI control. And I think this is especially important for some of you folks that either are prone to leaks or very short breaths. Now, TI control is typically manipulated by your respiratory therapist. Usually the physician does not order these settings, so this is important that your therapist be up to date on how to set TI control. And what it is we can set a minimum time for the breath and a maximum time for the breath. So normally you inhale and exhale as you like, what's comfortable for you. However, if you try to have a very, very short breath, that might not be enough time for adequate gas exchange. So we can say the breath has to last at least this long, but no longer than this. So I call it putting brackets around the breath. It has to be at least this long, but no longer than that. Somewhere in the middle, the patient can cycle the breath. So let me show you what happens, why it's so important. In this example, we're looking at another example of a leak being created. So here we have the patient effort along this bottom line. The next line, the blue line, is the inspiratory pressure, the IPAT pressure, and then the volume that's delivered to the patient. So we created a big leak, again, right here. And when we created that leak, do you notice the ventilator gave one extra breath before the patient asked for it because it saw that big leak and thought that was the patient asking for a breath. So that's an opportunity for dyssynchrony. We have a big leak, big giant leak, so we have an extra long breath, and then what we call one auto-triggered breath, and then we're back in sync pretty well. Now what we can do to reduce that asynchrony even is we can set that TI maximum. So on this particular patient, exact same situation, we created the big leak right here, but notice the difference between this breath and this big long breath. Okay, the difference is we put in those brackets. We put in that TI max right here. And we said, this is the longest breath we'll allow this particular patient to take. And that way, when they have the mask come loose, they get the big leak, they don't have an abnormally long breath. And look how quickly synchrony was restored because we set this TI max. The very next breath is right in sync. So we only had one breath, just a tiny little bit extra long, and the very next breath was back in synchrony with the patient. So we can use TI max setting to ensure synchrony in leak conditions. Now just for fun, I wanted to show you a competitive product, exact same test, exact same settings. Here I created a leak right here. And you can see this super long inspiration because of that leak. This is on that competitive product. You can see the tidal volume on that breath shot way up. It's enormous. But what's especially important is look how long it took. That ventilator did not get back in synchrony. Here's a patient effort, but there's no breath right there. Here's a patient effort, too late. Here's a patient effort, no breath. Patient effort, no breath. So some machines, if they don't have good leak compensation, they don't stay in synchrony with the patient. And that's probably the #1 most important feature for a ventilator for you folks that are looking for something to be comfortable and therapeutic. We've got to manage those leaks. That's the most important. Secondly, we want to ensure that you have time for adequate gas exchange. Now what I'm showing you here, Dr. Bendit mentioned some consensus statements, and this is a consensus statement from the Journal of Clinical Sleep Medicine, and they're referring here to patients with neuromuscular disease, or as we can see, this young man has severe scoliosis. Now what happens with some of these folks is we don't have adequate time for gas exchange. The restrictive process, the air comes in and comes back out too quickly for gas exchange. So that's what I'm trying to show you here. It takes time to go from the alveoli into the capillary. So this particular group of physicians in this consensus statement said a minimum IPAP duration, if available, may be increased so that the device does not cycle prematurely. Now what they're talking about here is TI minimum, being able to have a device that allows you to set a minimum inspiratory time. So again, we're talking about those brackets, the TI minimum and the TI maximum, and setting this TI minimum ensures we have adequate time for gas exchange. So real quick, I'm going to demonstrate that too, or rather my good friend Sam is going to demonstrate it. Okay, let's get him started breathing. And right now, we don't have a TI-min set for him. Okay, so right now he has no TI-min set at all. And we can see that he's triggering all his breaths, and they all look pretty short, don't they? He comes up to the pressure and pretty much dumps it out quickly, and he's got a fast rate going here. So we might look at that. The respiratory therapist can look at that and say, you know what? I'd like him to have a little bit longer time for gas exchange. So what we're going to do is set a TI minimum, and I'm just guessing here on where to set that. Perfect. Can you see the difference instantly? You see? Now the machine is telling me here that TI min is active, as if I couldn't tell just by looking at the difference. See how quick this breath was and how this one is elongated. He has more time there for gas exchange. Now what will probably happen to his respiratory rate now? It's going to slow down, isn't it? So you can see how this TI min can make all the difference, both in his rate and ensuring that he has adequate time for gas exchange. Thanks, Sam. Thank you very much, sir. Okay, so in summary here, let's see. This darn thing makes me start from the beginning every time. So in the interest of time, I think I'll just make sure I didn't have any other super important points. So we covered how important leak compensation is. We covered the different terms for non-invasive ventilation. Oh, one more important point, because Dr. Bendit did mention it as well. So another super important point for us is humidity. We need to humidify the airways to ensure your comfort, but it's not just a comfort issue. What happens to your secretions if they get dried out? They stay, and where do they stay? Right, and what's that a breeding ground for? Bacteria and infection, and that's something that you don't want to have. So we are big advocates for what we call integrated humidity. You can see on our ventilator here that the humidifier just connects right to it. But we go one step further, that you can also have the wonderful heated tubing here. So if I don't have the heated tubing, that's helpful. But what's going to happen if my room's a little bit cold? Yeah, I've got this warm air coming down that cold tubing, and what's going to happen? It's going to condensate. I'm going to have rain out. So that can be both annoying to me, and it can bother my therapy. So we're big proponents at ResMed of our what we call climate line tubing, this nice heated tubing that's going to help keep you comfortable as well as keeping your secretions moist so you're able to get rid of them. Okay, so let me get to my last slide and we'll just see if there's any questions, so I'm keeping you right on time. So are there any questions about any of this information? Yes, sir?
Are there defaults for the eye time if one is working in an ambulatory setting and we're just prescribing some of these more sophisticated algorithms for some of the patients that need complex, if you will, central?
Right.
So, you know, if we're not able to does it come with default eye time settings that are fairly appropriate for most patients?
Well, we have to, it's all based on the patient's respiratory rate, really, if you think about it. Because if the respiratory rate is 30 versus the respiratory rate of 10, my TI minimum and TI max, technically I should be adjusting those based on that patient's breath rate.
So from the ambulatory sleep study, we can look at the respiratory rate. then, and then make a guesstimation as to what the eye time should be?
Absolutely. We have a wonderful little chart that makes it so easy for you. If you catch one of us afterwards, we'll make sure to get your information so we can get you that little chart. But you can simply look at the patient's respiratory rate and look it up on the chart, and it'll give you some suggestions for that TI min or max. Of course, you can do it the way I always do, which is if the breath rate's 20, that leaves how many seconds per breath total? 3. So I know I want an IE ratio of 1 to 2, so you can ballpark it as well. But just to make it easy for you, we have a nice, what we call a TI control chart that'll help you. It's so crucial, though, when you think about how setting that TI max helps with leaks, suddenly the light bulb goes on and you see how important it is to do so. Yeah. Other questions? Yes, sir?
I have 2 questions. First one is, how many of those problems that you have respiratory-wise or sleeping-wise, then you should be evaluated for whether or not you need an IPAP or CPAP?
Ooh, boy, that is an excellent question. If I knew that I was prone to hypoventilation, if I had some type of diagnosis that made me think I was prone to that, I wouldn't wait long. If I had just a couple of those signs or symptoms, I would definitely be bringing it up with my physician.
Okay.
I sure would. Because the consequence, it's easy to treat. You know, non-invasive ventilation is relatively easy, and, you know, why not avail yourself of it?
Okay, and the second one is, a lot of times when you do finally be evaluated and you get to get a product, a lot of times it goes through Duro Medical. How do you get them to decide on the equipment that you and your respiratory therapist have decided upon?
Yes, and that is such a challenge. I really can appreciate that. That the easiest way, if you're able, is to have the physician specify on the prescription. If the physician writes on the prescription, I want ResMed, VPAP ST, whatever he specifies, but that exact unit, that's what they need to provide for you. So that's definitely your easiest way. Obviously, you can advocate for yourself, but it's a little bit easier if the doctor just orders it in the first place.
Thank you.
Yes?
Angela, I am having problems with dry throat, and even though I keep the humidifier at like 1 to 6 at the same every night, and I don't think that the temperature changes that much. What should I be doing?
Well, the first thing I would check on is, are you having undue leak? Because there are times if you're having a big leak, what does the machine do when it sees a leak? It's a good thing that it does this. It compensates. Exactly right. It compensates. That's a good thing. But how does it compensate? By sending a lot of extra flow. So sometimes that flow can be very drying, that extra flow. So are you using the heated tubing?
Well, I've got a Respironics BiPAP APAPs.
Okay, I see. The heated tubing will make a help for you. Our device, of course, I think it's the best. Our climate line therapy, you can set the temperature that you want, and it's going to keep it at 80% relative humidity there for you. So let's talk about how we could help you offline, but I do think that would help you. And manage that leak, because that might be what's causing the high variability. Of course, as Dr. Demaria mentioned, our personal fluid intake in our bodies changes day by day based on how much salt we ate, how much alcohol we're drinking, if we were sweating. All those things can impact your overall humidity deficit, and that might be playing a part in what you're feeling as well. Oh, yeah, absolutely. Yep, we only have time. We'll take one more question.
Yes, I am I just started using a CPAP machine about 2 weeks ago. And my problem is that I snore a lot. I don't have so much sleep apnea. I have very mild sleep apnea, but I snore a lot. And I'm still, with a nose piece, with a nose mask, I'm still feeling the same effects when I wake up, like the sore throat and the, you know. So I'm not sure. I increased a little bit the humidity from 3.5 to 4, but I'm still feeling like if I was snoring all the time. And
Did
you're not
you-
supposed to.
Did you mention that you're just using just a nasal mask, not one for your nose and mouth?
No, just the nasal.
You know what you might like if you stop out at our table? It's my favorite mask is my favorite mask for neuromuscular in general is called the Liberty, and it goes over the mouth with just 2 little prongs in the nose.
Yes, my
So
husband uses that.
it's not intimidating like a full face mask,
Right.
but I'm wondering if that might help you keep your mouth closed and help with that snore and the leak problem.
Thank you.
Let's try that.